Today's didactic is from Mel Houser, who is a medical doctor with All Brains Belong VT, um, that I've had the pleasure of connecting with in the past. She's an outspoken advocate for neurodivergent health needs and has done some incredible work to organize medical resources for providers and patients. Check out the All Things Project. Mel sees patients in her clinic that deal with conditions like EDS, MCAS, and POTS, along with related GI and sleep issues. I'm so excited to learn from Mel. Thank you so much for being with us, and I'm excited.
Well, thank you so much for having me. Um, oh, that's amazing. Callie shares in the chat. That makes me so happy to hear that. That's awesome. Well, hello everybody. Let me share screen. I'll get you oriented to our conversation. Amazing. That's really cool to hear. Oh, would it be possible to give me screen share privileges? Wait. Callie, did you use the everything's connected to everything tool in order to have a conversation with a provider who didn't know anything about this? Is that what you're telling me?
I did. I'm so excited over here. I search your name on podcasts. I use the tool, I give it to all my neurodivergent clients. I was just talking to someone today who I noticed they get chest times like I do when they're really emotional. And I was like, let's think about that. And they're diagnosed ADHD. So yeah, I'm so excited.
I'm so humbled and grateful to know that, and I'm sorry for like all the road leading up to that you needed an online tool in order for a provider to be open-minded to listen to you. And that's
Yeah.
the experience of like so many people. And in fact,
Yes.
the tools that I'm going to present about today, like that's why we created them. We created them because this stuff is not part of medical education. And and you all are on the front lines. You all are the people they feel safe with, and um, you are much more likely to hear about the details than a person's primary care clinician in many cases, because not only is the environment not safe to the environment thwarts access needs, or people aren't even able to communicate at all, let alone about at the level of the detail that needs to pattern match for the professional to even be able to pattern match. So anyway, thank you for sharing. All right, so you heard I'm Mel. I use she, they pronouns. I'll tell you a little bit about my organization, All Brains Belong, at the end, but we're going to talk about the big picture of neuroinclusive healthcare and the health conditions that have already started to come up. All forms of participation are welcome. You can have your video on or off. Even if it's on, I don't expect anything of you. Please feel free to move, stim, eat, fidget, all the things that needs doing. You can communicate however you're most comfortable. I'll stop throughout my talk to pause for questions and stuff, but you don't need to wait till then. Just you have a thought, don't tax your working memory, just throw it in the chat. I have the kind of brain that if I see it, I will probably interrupt myself and answer it, but just throw your questions in the chat and or use mouth words when we pause. Okay. But one more thing just about access. I'm a recovering New Yorker. I speak way too quickly. I work really hard to tamper it down, but like am mostly unsuccessful. So please feel free to flag me down if you need me to slow down or go back or anything like that. Closed captioning, just as a reminder to if you need it, turn it on. All right. So a little bit about me. I'm a family physician, and at this point in my career, I am mostly supporting neurodivergent kids and adults, often multi-generational families. And though I have a bunch of training in this regard, what I have learned the most about brains through is parenting. I'm partial to say that I'm a student of the world's wisest 7-year-old who has taught me more about brains than any of my professional training, really. Because when they were born, uh, it became really clear that I didn't know what I was doing and that my medical training was profoundly inadequate for their needs. I'll tell you a little bit about what I was trained in as it relates to autism and ADHD, which was largely an unhelpful narrative that was missing like most of anything useful. But I didn't know that at first. At first, here I am on the left, picture of me. I'm a doctor who takes care of babies with extra training in child development. Like I really actually thought I knew what I was doing. And my baby felt otherwise and let me know by screaming all of their waking hours for their first 2 years of life. And thus began my journey of learning and unlearning. And along the way, discovering about my own brain. In medical school, though, my training was really left a lot to be desired. My preclinical training, I don't know what you're all experiencing in your training, but this was mine. I got a 1-hour lecture about autism. It focused on the triad of impairments and like a rote list of co-occurring medical conditions. Just like, yep, this is the thing that the people get. And then when I got into clinical training, the stereotypes that I had heard about in lectures, yeah, that's what I saw. There was very much an emphasis on red flags, preventing, treating, all the things, and it was strongly implied that this was a rare thing. And the hidden curriculum, the narrative underneath it all, was that there's one right way to develop this hierarchical, linear way. Like this is how you play, and this is how you learn, and this is how you're, essentially a human. Of course, we know that's not true. So we're going to take a look at the literature on the systemic barriers to healthcare access for neurodivergent people. We're going to talk about the pattern of medical conditions that are going to present to you all, often before they present to anyone else. And I'll tell you a little bit about our practice here at All Brains Belong and some of the things we do here. Okay, so I'm going to play you a video, and I always forget the motor plan. I have to stop share and reshare and click the share sound button. I had to skip that part. Okay, I think this is it. No, come back over here. Here we go.
I'm terrified to go. I can just feel when I walk in, I don't know if it's a safe space for me being neurodivergent, but I also don't know if it's a safe space because of the way that I'm going to be treated and disregarded in terms of like, just go lose weight.
Nobody believes you. Everybody looks fine, so it has to be fine.
Understand, everybody's access need is different. We're all different. We're not the same.
Sort of designed for you show up and they send you places and put you in little cubbies and folders. And if you actually are like, no, nobody quite knows what to do with you.
So that's the story that I am most typically hearing when I meet a new patient at our practice. A lot of the folks we take care of have been really suffering for decades with chronic medical conditions, and what they perceive is that they have been dismissed, invalidated, gaslit, and really traumatized by their healthcare experiences. And that's what the literature says too. So what we know is that autistic and ADHD patients have poor access to healthcare and poor healthcare relationships, despite this being important to the patients. We have a free community education program called Brain Club at All Brains Belong. I'll put the link in the chat. Where, oh, interesting, Zach. Do we know the percentage of non-autistic people who report a good relationship with their PCP? I don't know that literature. That's really interesting. Yeah, as a comparative data point, it's really interesting. No, I don't know that. I don't know if anybody else is familiar with that literature. So Brain Club, it's community education about everyday brain life, and so we have community panelists and guest speakers about all kinds of topics, and we cover healthcare about once a month, and we have lots of panels of people telling their stories, and panels of primary care physicians actually about learning and unlearning and what it's been like to learn about some of the things we're going to talk about today, which is been pretty interesting to do. What we know is that the barriers to care cluster in these three areas. There are barriers in the environment or interactions with the environment. There's barriers related to the provider. That is that autistic people in these studies perceived that their providers had insufficient knowledge and skills to provide care, and that specifically harbored unhelpful attitudes that interfered in providing care. And of course, the system. There are so many defaults in the healthcare system. You must pick up the phone to become a new patient, and make an appointment. You must fill out the 20-page packet, like all the things. Anytime there is a default, anybody whose brain works differently than that is going to be othered. And of course, the healthcare culture. Like I remember as a trainee, I'd be a medical student and somebody would make it, like somebody supervising me, make a comment like, oh, there we go, there's another patient with the list, as though there were anything wrong about organizing your information in writing. Or when I'd rotate through the emergency department and somebody supervising me would make some comment like, oh, there's a positive cell phone sign. They can't really be in pain, as though someone who's able to operate a cell phone that is in any way connected with their experience of pain in their bodies. This is what goes on. The knowledge piece, when you're only trained in stereotypes, that is all you see. So this study out of Kaiser, Zerbo et al. In 2015, less than 10% of primary care physicians would suspect their patient is autistic if the patient volunteers information, shows interest in people, discusses emotions, and can see the whole picture. As an autistic person, I find this profoundly offensive, and yet not surprised. Of course, there's all the language that is so commonly used in the traditional healthcare system. And what many of my patients share is that when they hear a provider say, use functioning labels, or, even actually say autism spectrum disorder, these words suggest to them that the provider is operating in a paradigm that is different from the paradigm that the patient wants to be in, and therefore cues unsafety and impacts the relationship and the interactions. And then, of course, the shift away from the medical model of disability, or rather than list a collection of deficits, thinking more through the lens of the social model of disability, where the amount of disability that someone experiences is relative to the barriers in their world. And I think when it comes to visible disability, those we can tell by looking. If I approach a building that has a ramp and I use a wheelchair, I'm going to have less disability than if I approach a building that does not have a ramp. And when I show this slide to primary care audiences, they can't wrap their brains around it, because they were trained in this and they've never heard of this. And it's radical. But that's not why we're talking about this. We're talking about this because neurodivergent patients are dying. Autistic people die on average by 36 to 54 years, with leading causes cardiovascular disease and suicide. Autistic adults have a 3 to 9 times increased rate of completed suicide. ADHDers, 4 times increased risk of premature death. So when I learned this, I flipped my lid. I was 37 and I had just gotten my autism diagnosis. I am still the parent of an autistic child. My child was 4 at the time in which I learned this. And it was like this parallel universe of like, how was nobody talking about this? Why was nobody doing anything about this? And so I quit my perfectly stable job and started All Brains Belong, where we, over the past 3 years, we're a toddler nonprofit, just 3 years old, been trying to reimagine healthcare and community connection, and integrating medical care into so many other domains that our people need support with. We like to say that to do anything for the neurodivergent community, we have to do everything. In traditional primary care, I was spending like the majority of my time in the exam room, like problem solving life outside the exam room. People were lonely. People were struggling to access employment or keep employment. Kids struggling to access school, and their families struggling to fight with the system. So it just intuitively made sense that how would we help people get, quote, healthy if we weren't addressing all these other domains of life, especially because, as we know, loneliness has the equivalent impact on health as smoking 15 cigarettes a day. So we have programs in all 4 of these areas. Our medical programs, so we are providing medical care for neurodivergent kids and adults. We have primary care programs, but we are also folks, they keep their primary care and they come for support for specific medical conditions that they've heard that we know something about. So the medical conditions we're about to talk about now that are more common in neurodivergent people, including hypermobility spectrum disorder, Ehlers-Danlos syndrome, mast cell issues, POTS, dysautonomia, long COVID, etc. We do a lot of gender-affirming hormone treatment, especially for folks whose primary care physicians do not offer that. And in our area, I don't know what it's like out where you are, but in our area, we are the only medical practice with a universal mask mandate in our county. So people come because they are unable to safely access healthcare anywhere else. All of our programs are informed and driven by what our patients say they need. So when we began, we had community focus groups and surveys and interviews and tried to figure out like, what do people, like what's wrong with healthcare? We knew what the literature said, but what are our local people? What do they need? And we keep trying to do those things because it turns out it's not that hard. You just ask the people what they want and you try to do those things, and you ask them what stresses them out and you try to not do those things. What most people are looking for is to be listened to and heard and believed. It's free to believe people. So it's a small practice. We have about a little over 350 people. And our community programs who serve folks beyond the medical practice, so they're open to anyone, anywhere. And I'll tell you more about our programs. Yeah, I agree, Gabriella. It's sad, so sad that this is radical. So much of what we're doing is providing people a place where they feel listened to and valued, and that they are meeting other people who are navigating similar things. Whether it's in our medical programs, we do a lot of group-based medical care. So either in medical programs or our community programs, I think that's a common variable. Like when you hear details of your own story reflected back to you through someone else telling a story, like there's something so healing in that. And I think what happens is people within a medical practice, they are shifting their own self-narrative. They think they're the only ones, and they're not. And by bringing people together as this little community health village of learning and healing, we've also learned some things that we didn't know before. And that's what I'm going to share with you now. I knew there were medical conditions more common in autistic and ADHD people. I knew that probably for like 3 or 4 years when I was still in traditional primary care. I was mostly caring for this population. But so I knew these conditions are more common, literature says that they're more common, I really had no idea that amongst it's certainly not a homogeneous group by any means, but certainly like the people that come to this non-traditional practice, they are more likely to have complex medical needs that weren't met by the traditional healthcare system, or they wouldn't have come. So amongst that group, 97% of our autistic and ADHD adults have a constellation of intertwined medical conditions. 97%. That is the biggest surprise to me of this whole journey. I had no idea. So what is this constellation? It is something involving the nervous system, sleep, the jaw and face, the digestive system, the immune system, connective tissue, both involving the musculoskeletal system, vascular system. Connective tissue goes through your whole body, so it could be everywhere. And what happens is the healthcare system, because of the systemic barriers, like the 10 to 15-minute appointment, for example, it fragments care, it fragments body parts. And what ends up happening is that because these conditions are intertwined, you can't like just treat one of them at a time, because sometimes the standard medical management of some parts of this cluster make the other parts worse. Example, somebody has chronic pain. They go to their primary care physician, and the primary care physician prescribes a muscle relaxant. Pretty common, pretty standard. Okay. Well, turns out they have an unrecognized connective tissue disorder characterized by floppy, extra stretchy connective tissue. So what happened? The muscle relaxant made the floppy connective tissue floppier, and now the ligaments are extra stretchy, and now the bones are sliding out of alignment even more, which is squishing the blood vessels and squishing the nerves. Oh, by the way, that's also affecting the connective tissue in the airway when their undiagnosed obstructive sleep apnea now is worse on that muscle relaxant, which made their dysautonomia or POTS, some type of dysautonomia, worse, which is now making their pain worse. And so without zooming out and recognizing the whole constellation as a whole, medical providers end up doing harm to people who have this constellation, and they don't know it. They don't know it. They're doing something that is standard, and they don't know it. And so a quote from one of my patients that I thought was genius: oh, it's like a ball of yarn where if you pull the wrong string, you make the knot tighter. You gotta find the right string to pull. Yup. So these are some examples, not an inclusive list by any means, of some of the very common medical conditions that you may see in your patients and clients too. So hypermobility spectrum disorder, and some people have a subset of joint hypermobility that might meet criteria for a condition called hypermobile Ehlers-Danlos syndrome. Dysautonomia, mast cell dysfunction, irritable bowel, pain syndromes like fibromyalgia, sleep disorders like obstructive sleep apnea or restless leg, migraine, endometriosis, myalgic encephalomyelitis, chronic fatigue syndrome, long COVID, chronic Lyme, any number of post-infectious chronic illness. Yeah, are we playing bingo? No, exactly. It's exactly, and that's the thing. So we do universal screening for this in my practice. You become a new patient, you fill out a thing, it's like, oh, I already know. And it is like bingo, because if you have a couple of the different systems impacted, you are more likely to have other systems impacted. And that's the thing. Like, not everyone who has irritable bowel syndrome has the constellation of intertwined medical problems. But if you have irritable bowel syndrome and fibromyalgia and migraine and a sleep disorder, like, you have this, you probably have this. So it's just really, 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 really common. And why that is, why they're all connected is because these are neuroimmune conditions. The nervous system and the immune system go throughout the entire body. So it would make sense that you have, symptoms in multiple different organ systems. I'm going to put a link in the chat if anybody wants to do their own driving. Okay. And I think what happens is a lot of times patients come and they're like, my sleep's really awful. I keep waking up with panic attacks in the middle of the night. I'm like, whoa, 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 whoa. That's not a thing. People do not wake up with panic attacks in the middle of the night until proven otherwise. You have dysautonomia. You have dysautonomia that's probably related to your sleep disorder. And because people get these, like, they get shoved into the boxes, like one of the patients said in that video I played you, like, they put you in the cubbies and the folders, like, why don't we just stop separating mental health and physical health? You have an autonomic nervous system response to something. By calling it panic, that is closing a door to be like, I don't know, I think like medical people, they stop like thinking. Once it's in the panic box, they stop thinking. And I think that that's not good for patients. So I'm gonna play you another video.
I was in my early
Oh, that's too quiet.
40s, I started having a lot more symptoms that I would had related probably at that time to more mental health than not connecting my mental health to my physical health. I would get these sort of odd, mysterious rashes or odd, mysterious symptoms. Like I would get so sick to the point where I would like get like I've had mono twice or I'll get pneumonia. And so then I would have, what would be considered asthma. When I first applied to ABB, when I received the list of all of the things and all the symptoms in the different buckets of the systems in the body, I couldn't believe I had something in every bucket. I had something in every system, but I had never put them all together before. Once I came into ABB, the turnaround for me physically was so quick by understanding that I wasn't having panic attacks in the middle of the night. I actually have dysautonomia, that I wasn't lazy because I don't want to go for a walk. It was the fact that I was in tremendous pain and all the things are related. So if I have what I would call now not a panic attack, but I would call like a sympathetic nervous system reaction, that could trigger my mast cells. So if I went to a family party and I had a difficult interaction and came home and was just set off, in terms of my nervous system, shaking, feeling buzzing in my body. The next day I could wake up and my whole body would be covered in pain and creates tightness within my muscles, which impacts my hypermobility. Now I'm no longer able to walk. But now, because I know what that is, I go to group medical visits, I double up on my mast cell medications, which is just like simple medications. And I'm out of pain so much more quickly.
Do you see these patients or clients? See some nods. Yeah. Are night terrors part of dysautonomia? What a wonderful question. I think for many people, they very well may be. Reading the chat, so many parts of me get so excited listening to all this because they're all themes that I'm very passionate about, both personally and supporting clients. I changed the window and then I lost my the practical struggle is that I can name how all these systems are dynamics bumping up against each other. How do we find providers who are actually willing to take a step back and take a holistic look rather than keep referring people to the specialists? Oh, I hear you. So I'm gonna work my way. I think it's maybe in the next tool or two. Actually, it might be later in the presentation of of a tool that you can hand to your client so that they can hand it to their primary care. This is a primary care thing. Early on, when we first started seeing these patterns, we're like, oh, we got to better understand this. So we formed a task force in 2022. We had this big task force of interdisciplinary professionals, OTs, SLPs, PTs, patients, and multiple specialists, medical specialists. And like, really what it came down to is that the specialists, they like literally couldn't. They just couldn't because their monotropic focus is their thing. They literally can't connect it to the other things. It's not how their brains work. It's fine. So this is a primary care situation. And so the tools that we've put together are really about empowering and empowering primary care to do the thing because their brains are more likely to be able to do this. And it often involves some like coaching your patients and clients with some scripts on how to have those conversations. Okay, so in 2023, we got a grant from the Organization on Autism Research and ARP, and we made this resource with co-created with more than 100 autistic and ADHDers in our community. I am going to put, so you can get to that link from the other link that I put already, but I'll put this directly to the clinician resources, which is the best part of the project. Because what that does click to access the Autistic and ADHD Health Guide for Clinicians. It's open to everyone. It's free. And it is a 16-page evidence-based document that basically teaches a primary care person how to identify this is what's happening and then how to manage it. And a lot of the management are over-the-counter medicines and supplements. A patient could like do what they want with it. So it's, thank you, Gabriella. So it's there, it's available. We're really excited about it. We just hit the 20,000 mark. There's 20,000 unique humans who have accessed this resource, which we're really, really excited by. And like devastated that there are 20,000 humans who needed this tool. I'm just gonna skip, actually. We're gonna do all of this, but I'm gonna skip to this part. So the thing that I would drive your patients and clients to, I mean, they can go check this out, but the main link, the all the things link, they're gonna come here, individuals and community members, and they're gonna click this. It's a letter that is meant to bridge the double empathy problem. It is a letter written for primary care clinicians in the language that they are used to receiving. And what it does is it brings them directly to the clinician guide. And so, and there's a video on this page somewhere. Yeah, this video with a tour of it. It's like, it's trying to teach people what I'm about to say next. It really works a lot better as if nobody says anything else. It's just like, oh, I found this on the internet. Here you go. That works often a lot better than like a whole bunch of other information. Certainly, I would not recommend, printing out the 16-page guide and handing it to somebody who's already drowning. Right, the healthcare system unfairly expects a primary care clinician to do all the things in a 10-minute visit. So to read 16 pages, like that would trigger my nervous system. So the letter, it is setting it up like, yep, your patient is autistic or ADHD. They are more likely to have a constellation of related related neuroimmune conditions. Here you go, if you'd like. And we've gotten feedback that has worked better than providing a whole bunch of other information. That's awesome, Nicole. So I'll put the direct link to the letter in the chat as well. Okay. Back to where we left off. All right, so I wanted to also share a little bit about some of the other things that we do here. Also that, at the beginning when we talked about that radical concept of asking people what they need, this is like the downstream consequences of that. Of course, we know we all have different brains, we all have different needs. So, and somebody mentioned in the chat a little while ago about universal design. That's the concept. The concept is just offering things in multiple different ways so that more people can access them. Because everyone has access needs, and it's just that, if I design a practice that only works for my access needs, people whose brains work like mine, they're going to be able to access it a lot more easily than people who don't. And I love this quote from one of my patients. I don't know what my access needs are. I just know they're not being met. Yup. And so the idea is When you think about all the different types of access needs that, you know, might come up in a setting, whether that be a healthcare practice or school or work or whatever, and you think about all the possible barriers and solve for them by introducing a couple of different ways of accessing it. That's it. That's all we do. And when we think about, you know, the sensory processing and the executive functioning and the motor planning and sequencing, all the stuff that's going on in the background, it's like this stuff's such, if these are not supported, people may not be able to access their healthcare. And we're all going to be different in terms of how much of our battery is drained. And of course, when we think about, you know, this population has higher rates of chronic illness. And so, you know, the battery or the budget, the pie chart's going to be, you know, extra drained by not only these things, but pain and, you know, your mitochondria not working and all the other things. I'm going to play you, I think it's our second to last video.
Get to see people come in who haven't been able to get care anywhere else.
Do you want bright lights, low lights, fidget toys? Do you want to have time check-ins? Do you want to have summaries sent? These things are an option? What?
What interests me about All Brains Belong is the idea of a customizable menu to make an experience, whether it's a vaccine clinic or a medical visit in the office or a community gathering event, feel good to each unique individual.
Being able to cue safety and adapt the environment for what people need.
What do you mean healthcare can be like this?
So everyone gets a menu with their choice of setting, you know, indoor, outdoor. Some people like they literally need to access healthcare in their car, in the parking lot, because that's what they can access. Multiple different ways of scheduling, multiple ways of communicating both during and between appointments. We have folks who, you know, they come into the office, but they're texting us while they're sitting next to us because why not? That's how they best communicate. You know, executive functioning supports, you know, both between and during appointments, whether that be, you know, visual schedules that could be text or pictures. People choose from any number of things. They're also picking, this is kind of what it looks like, thinking about learning from folks, you know, I don't want eye contact, don't ask me direct questions, use short sentences, just the idea of like, yep, these are things we're all thinking about. Okay, there we go. So what sensory processing support looks like here, I'm just going to go through some of the common things. We very intentionally do not have our office look like a healthcare environment, because so many of our folks have such healthcare trauma that they walk in and they're in a building that looks like the usual healthcare environments and the fluorescent lights and all the things. Anyway, they have these limbic responses and they haven't even started the appointment. They just set foot in the room. So we very intentionally have this feel like a living room. This is the waiting room, and we only have one person scheduled at a time. And this is the exam room. But you know, most people don't have control over their environment. Most professionals don't have control over their environment, but there often are some things that people can do anywhere, including giving people a different choice of where to wait, including, you know, like having it be an option to, you know, text me when you're ready. I'm gonna sit in my car till I'm ready. As I said, outdoor, indoor, car, telemedicine, of course. People choose dim lights or bright lights. Sometimes when we do things that involve multiple people, like if we do a vaccine clinic, if someone has requested dim lights and someone else has requested bright lights, those are in fact mutually exclusive, so I cannot schedule them at the same time. So that's like, that falls to me to figure out how to navigate conflicting access needs, but I'd rather know that than have someone be dysregulated. choosing from different furniture, choosing temperature, background music, no background music. Some people request to have the door left partially open if possible. And then lots of different types of grounding and focus tools available, and we're like readily normalizing their use. Normalizing that there's no right way to communicate. So, I mentioned the example of the person texting while they're in the exam room with me. So, we have paper out, and some people doodle or write, or some people even text while they're sitting here. You can communicate however you want. Just naming that explicitly sometimes can really go a long way for people, because it would often never occur to them that they could start texting in the middle of an exam room if they are a part-time AAC user. The phone is a problem for a lot of my patients. So figuring out ways to, great. There's a question in the chat about restrictions for accessing care. We bill insurance. Most of our folks have Medicaid and Medicare, but I only have a Vermont medical license. So at this time, we can only provide medical care to folks who live in Vermont or are located in Vermont. Multiple ways to schedule, multiple ways to request refills, multiple ways to do pre-visit planning. It benefits everybody if someone communicates best with extra processing time and in their own space, and they send it to me by email or Google Forms or whatever, and I have it. It benefits me because one, I can process it on my own. I can read and then not have to talk at the same time as reading. That benefits me. I also can put it right in my note. That also benefits me. So it's just reimagining what the possibilities are. And of course, normalizing multiple ways of communicating. What I want to say about executive functioning, and I share this with like great remorse, to be honest. Like when I worked in traditional primary care and somebody would miss an appointment, I had something to say about that because everyone around me did. It was part of the culture. There was judgment and assumptions made about how engaged someone was or how motivated someone was and all the things. What is that? That's ableism. Like they missed appointments because of their disability. They missed appointments because it requires so much executive functioning in order to access medical care. So we do a ton of executive functioning support. Hold on, I need liquid. Not just reminders. We have a fancy scheduling system that does automatic reminders, emails, and text, but we do a lot of manual check-ins, a lot of offering of extra stuff for people. Our patients are recall dependent. They will not schedule. If they get lost to follow-up, they will just get lost to follow-up forever until they're in crisis. So we have to have systems for periodically catching that they have not been seen in some time and recall them. Pre-visit planning, I mentioned, written agenda often helps folks. Support for time management. Some people ask for, because it's on the menu, let me know when there's 5 minutes left. Let me know when there's 10 minutes left. And then, of course, concrete action steps. And it doesn't need to be done. Part of the reimagining is this doesn't have to be extra. It can be done during appointments. So if someone requires for their executive functioning for me to make a list of action steps, I'm gonna use some of our appointment time to do that with them. We're gonna do it together. I'm gonna send it to them. We did it together, and then I sent it. And then, of course, to navigate the rest of the world, making calls, doing research, creating extra visual supports, and we do that together during appointments. When I don't do that, and I forget to do that because of my own executive functioning, and then of course, it doesn't work quite as well. We already skipped to this part where I showed you the clinician guide. Letter. And then the last thing I'll mention is just about protecting patients from COVID. Neurodivergent people are at increased risk of long COVID. People with hypermobility are also at increased risk of long COVID. Put those things together. That's a lot of increased risk that a lot of people don't know about. If you have mast cell dysfunction, if you have any of these other things, all of those things are independent. If you look at the clinician guide, most of these components of the constellation have research to support the correlation between that thing and long COVID. And we also know that the more number of times somebody gets COVID, the higher the risk of long COVID. We also know that long COVID is the fast track to dementia, and that the only way to not get long COVID is to not get COVID. So it's really this very strange time in history. And a lot of folks are feeling like they're having to choose between full and meaningful participation in their lives and protecting their health, particularly if they've already had COVID, let alone already have long COVID, and they recognize the stakes for getting it again. So, of course, masks, air purifiers, being outside when we can, and we just, we've had air purifiers this whole time, but we just got this really good air purifier that makes us feel good about doing in-person groups. We're really excited about, because patients, they wouldn't come. They're afraid. They're literally afraid to access healthcare. And if I can't cue safety, that it's safe to come to this place, I don't think anything else matters. All right. So, connecting with All Brains Belong. This is a program that I wanted to make. Oh, I want to stop for this question about studies suggesting neurodivergent people were already at more risk of developing dementia. Yes, that's true. Do you think having long COVID will exacerbate that risk? I do believe that. I do. And that's terrifying. It's terrifying. This is a good place for me to actually, I'll pause for more questions before I get into warm and fuzzy things.
I guess one other question I have is, are you like ever available to do presentations like this for medical providers? I often have some ins and would love to pull you into something like this.
Yeah, love to. Absolutely. Absolutely. Right. I think often it's, and we've been really, it's been like, I'm really optimistic that by finding open-minded gems who get it, recognize the gap, recognize the shortcoming of or at least who will believe watching something like, like the clips I even though I didn't need to play that video for you all because I already knew you were safe people and that you got it already, but there are clinicians who they don't know. They don't know that patients feel unsafe when they're accessing help. They literally don't know that. And when they learn that, they're like, what? I don't want that. And so it's new information. The idea that patients feel unsafe, patients feel hurt, patients feel like they don't want to go. Oh, I think I should probably or there's professionals who, very very appropriately are like motivated to do something about health equity. And then you show people that like there's this whole group of people who die prematurely. And there's literature showing that people, they literally can't access health care. Oh, I should do something about that. So it's if you've got folks who want to learn, that's awesome. And in fact, a free thing you can direct people to. Let me get the URL correct. I'm doing a free webinar about this constellation of intertwined medical conditions. On Tuesday, January 14th at 6 o'clock Eastern, and it's also going to be recorded. And there's the link in the chat. So Zach, if even like, even if you didn't find anyone who wanted to like invest in a training, but they like would be willing to watch a free webinar, that'd be a great start.
Awesome. Thanks so much.
Absolutely. Taylor's got a question in the chat. Do you have info on vetted clinicians to refer clients to in the Seattle area? Oh, I totally wish that I did that. We just started in Vermont. We just started a community nominated local to Vermont neurodiversity affirming, which also means that you need to be knowledgeable about the constellation. You have to be gender affirming. You have to be COVID safe. All the things that go along with being neurodiversity affirming. Specific to Vermont though, so unfortunately I don't have any Seattle resources. I'm sorry. But like that's and it's hard, right? Because why do I want that guide? Like on one hand, I want that guide so that the people can access resources. I really want that guide so that when I need to send my patients somewhere, I have I don't have a big long list of neurodiversity affirming mental health therapists to send people to, or PTs who know about EDS. I don't have that list. So that's where we came from in creating that project. And it's really hard because anyone who gets nominated, we then have to vet and see what their deal is. We also really want to make sure from a financial accessibility standpoint, we want to make sure that people who can accept insurance do, and all those kinds of considerations. Oh, that's great, Zach. So Taylor, Zach's got a resource for you. That's awesome. But things you can refer people for. So this is a free community program. I should make a new slide, but I didn't. It's called Kid and Teen Connections. We recently changed the name because we learned that teens don't like a name that just says Kid Connections. It's always been open to ages 3 to 17. Now it's called Kid and Teen Connections. Let me put that link in the chat. So this is a free community program open to anyone, anywhere. It's a virtual, customized friend matching program. So a child or teen or their caregiver fills out a profile about what their interests are, what makes them feel comfortable, what stresses them out, and we make a customized friend match. This is a picture of little kids because I don't have a picture of the person who said this, but the person who said this quote was 16 years old. The parent sent an email saying that their 16-year-old said to them. So this must be what it feels like to finally have a friend. Chills. Like, it's not that hard to help people feel like they belong. And in fact, this program was invented by a kid, a former 8-year-old on our junior advisory board. At the beginning, when we were doing all the focus groups for adults, how we're going to design other programs, I asked a child on the junior advisory board, like, what do you think we should do for kids to help them feel like they belong? And without any hesitation, the sweet little love says, "You let us do what we love." What? Sure enough, that's it. That's it. I'm doing what I love, and they're doing what they love, and we feel like we belong. So anyway, if you have kids and teens in your lives, personally or professionally, we invite them to get connected. Awesome. Bye, Corey. Nice to meet you. And as we know, loneliness has a significant adverse impact on health. I told you the study on the equivalent impact of smoking 15 cigarettes per day, equivalent to the impact of loneliness. We know that autistic and ADHD brains in particular are monotropic. Fewer things captivate our interest and do so more intensely than other brains. So if I am a 6-year-old who has a monotropic focus on dragons, all I can think about is dragons. And there's no one in my class who loves dragons the way I love dragons. I'm going to have a really hard time forming social relationships. So it's the idea of connecting people based on their shared interest, not a shared diagnosis, a shared interest. So that's how that program works. And then, of course, in addition to webinars and trainings, we also have free community education. I'll put the link in the chat again. I shared it at the beginning, but I'll put it again. to Brain Club. We'd love for you to join us for Brain Club. It's every Tuesday night at 6 p.m. Eastern, but it's also recorded, and all the archives dating back the past 3 years are all available at no cost at that website. And it's all different kinds of so if you're supporting a child or their family, like this is another resource that you can send families to who may benefit from not just connecting with other families, but getting some education around to reinforce or supplement the topics that you're supporting them on. And then I will wrap up with one more video.
An opportunity to meet others.
But it's not loud enough. Strange.
An opportunity to meet others in the community who are going through the same or similar things, which then gives us the opportunity to learn from each other's experiences and to really value and feel valued by each other and feel a lot less alone and a lot more hopeful. And so it ends up feeling like a community more than a medical practice.
What I often see is once people feel safe and once people have been cued safety, they're able to engage in community. And that's when we really see these kind of healthcare jumps for people. We see, people come to group visits and learn from other people and have that shame reduction of, oh, it's not just me dealing with all these things. There's other people who believe me, there's other people who are like me, and get really quality medical care too.
To be in a community where I get to explore and learn about my brain and other people and other people's brains.
We're all in this together as individuals that, that sees things differently, hears things differently, moves things differently.
Smoothing out the rough edges of my experiences and of my perceptions. I'm less harsh on myself. I'm less sharp with myself.
Right? It's exposing me to people being so beautifully raw and authentic because the space allows that. And I can't think of many spaces in life that allow for people to come together in this way and kind of like this radical act of trust.
ABB to me has been a way to have community, have social connections, to understand my body, to reframe mental illness into, autism, to medicines that, simple medicines that have been able to make my mobility and my ability to be in the world different. ABB has given me a way to be myself and in community with others that I hadn't had in so long.